Thank you. Dr. Meacham, Dr. Monga, members and guests, happy Mother's Day, and thank you for the opportunity to present. Can we?
Next slide, please.
Erectile dysfunction treatment options include PDE5 inhibitors, vacuum erection device, intracavernous injections, intraurethral suppositories, and penile implants. Erectile dysfunction treatments attempt to improve erectile function without treating the underlying pathophysiology of ED. Can we heal the penis? Shockwave therapy has been used to ameliorate ischemia and promote wound healing in plantar fasciitis, Achilles tendonitis, and most recently in myocardial revascularization. Shockwave therapy is very different from S-wall for stones. S-wall for stones, all urologists are familiar with, is focal, has a smaller focal volume, and the energy is concentrated. Very different from ED, where the shockwaves are radial, the focal volume is larger, and the energy spread is over a greater area. In fact, the energy is about 10% of what we use for S-wall as kidney stones. The mechanism of action of shockwaves is not entirely understood. Two major theories have been proposed. One is to increase angiogenesis, which is used in myocardial revascularization, and two is to increase NOS-producing nerves and recruitment of stem cells. There's a large meta-analysis that we recently published. Raul Clavijo, my fellow, and Taylor Kahn put together a meta-analysis of 7 randomized controlled trials of 602 subjects. Median age was 60, and the follow-up was 5 months. The improvement in IIEF-EF score was 6.4 in the treatment arm and 1.6 in the sham arm. At the University of Miami now, we're doing a shockwave therapy clinical trial for men with erectile dysfunction. It's a randomized controlled trial to evaluate the safety and efficacy of shockwaves for ED. 80 men is the target recruitment, and we finished 15 men with mild to moderate ED, 2 treatment arms, 5 versus 6 sessions, and the same number of 3,600 shocks are delivered in both arms. This is the model, and it's a 6-month follow-up, and men cannot use PDE5 inhibitors, could not have had pelvic surgery, no diabetes, and should have a normal testosterone level. So the case that we will debate today is a 51-year-old man who complains of erectile dysfunction for 6 months. He grades his maximum tumescence at 70% of normal. His IIEF-EF score is 19, classifying him as mild to moderate ED. He has normal libido, has occasional nighttime spontaneous erections. He's married for 27 years with a 49-year-old wife. He's never tried PDE5 inhibitors. His past medical history is significant for hypertension. The rest of the medical history is okay. He's a non-smoker, and his BMI is 31, and his geo exam is normal. Of note, his labs testosterone is 478 and normal, and his hemoglobin A1C is 6.8. To debate this case and would you offer shockwave therapy, we have 2 legends in the field. First, Erwin Goldstein from San Diego, California will debate for the pro position, and Dr. Tom Liu from San Francisco will debate for the con position.
Ranjit, thank you. It's our pleasure and honor to be here. Happy Mother's Day. I just want everybody to know that I met Tom 1981 at the Heinz Convention Center in this city. It's now 36 years later, and Ranjit is only 35 years of age, so I know Tom longer and have been to more AUAs than he's alive. I thought that was interesting. Would I offer shockwave therapy to this 51-year-old male? So this is the summary. He has mild to moderate ED, is a perimenopausal partner, and we could talk about things about perimenopause that we would need to know, but we won't here. Cardiovascular factors, he has some blood tests. He's never tried PDE5 inhibitors. So this evidence-based, consensed, sort of durable paradigm of how to manage ED would not allow for shockwave therapy in this person, because there's identification, education, modification, so we could deal with his cardiovascular factors, his partner issues, his obesity, getting lower, his hemoglobin A1C. He's never tried PDE5 inhibitors. So he has not done the first line, second line, and third line therapy. So no, you can't really offer shockwave therapy based on how we manage erectile dysfunction in the year 2017. But he could be part of a clinical trial. And what we're doing are clinical trials to get this therapy cross the finish line so the FDA can approve it. So why shockwave therapy? I mean, we have everything we need. We have pills, they're amazing, but they're just not for everyone. They're contraindicated in people who can't walk up 3 flights of stairs. 30% of people it doesn't work. Half of people discontinue therapy. So the search for additional therapies is ongoing, and it will continue to be ongoing. So how do shockwaves work? Ranjit sort of went over this. I'm going to tell you that if I do this, that's almost like a shockwave therapy. There's a compression, expansion, a compression, expansion. You can hear the sound go through the system. There's a mechanical response to the shockwave therapy, and the best analogy we have is in endothelial cells and blood flow. During erection, as blood flow increases, the shear stress of the red cells across the endothelial membrane results in a biochemical reaction to that mechanical response. So we believe shockwaves do the same. They're involved in stem cell regeneration. They're involved in release of vascular factors. That leads to the clinical response and then the improvement in erections. So it's the translation of a mechanical, physical force to a biochemical benefit. So let's just look here. Ranjit went over this. This is a little more visual. In urology, we use things that are around 0.9 millijoules per square millimeter, and in the ED we're going to use 2 to 10% of that value. And instead of being extremely focused, it's going to be wider, and we're going to use this so-called low-intensity shockwave therapy to provide treatment. So in a petri dish sort of experiment, you'll find that you'll see benefit at really, really low energy values. That's 2%. This is up to 10%, but if you go to higher values, like 20% or 30%, you actually lessen the effect of the therapy. So it's like a Goldilocks thing. It's too low is not good, too great is not good, but there's a window where energy will improve the release of appropriate vasoactive factors. It's another basic science slide. There are 2 data sets on here. We'll just look here. You can see that the shockwave activates signal pathways and cell proliferation. There's just more cells here than there are in the unshocked therapy. There's more beneficial signal pathways involved when you shock. If you want to look at protein synthesis, you can see the proteins improve as you provide energy levels around 2 to 10% of lithotripsy. So that's very good. Nice to have the basic science. Here's 8 additional studies in basic science, all looking at animal data, looking at benefits physiologically of increased vascularization, increased perfusion, vasodilation, anti-inflammatory, progenitor cell recruitment, and on and on. The basic science supporting low-intensity shockwave therapy is really not that controversial. Okay, we're going to translate to the human. You're a person and you want to have management for your erectile dysfunction. So the management of ED goes this pathway first. Ideally, there's a diagnostic strategy involving, if you like, a biopsychosocial sex therapy, pelvic floor physical therapy, history and physical, endocrine, neurologic, and then a series of tests of your erectile function. That traditionally has led to what we call symptomatic treatment. Symptomatic treatment involves pills, vacuum devices, constriction devices, pellets, self-injection, and penile prostheses. We're going to introduce to you, through shockwave therapy, a new paradigm. And the paradigm is called disease modification. Can we take a pill and then you wake up the next day, you still have the same erectile tissue? If you undergo shockwave therapy, what we hope it will do is change the health of the tissue. So that's a disease modification. So injections, pills, implants don't really address pathology reversal, but low-intensity shockwave will. So that's the difference. Tom Liu's group in San Francisco did a series of meta-analyses. This is one of them. There are others who have done meta-analysis. Ranjit spoke of a meta-analysis. You can see that higher energy flux density, in that range that we're talking about, 2 to 10% of lithotripsy, significantly increased IIF in 14 studies that they looked at. And then they found that if you went at that energy versus that energy, the higher energy gave you better, although not statistically significant data, Another variable beyond energy is how many shocks you give in a treatment session. So 5,000 did better than 1,500. And then how often do you do this? Do you do this once a week for 6 weeks? Do you do this twice a week? They found that treatment once a week for 6 weeks had a better IIF data. So I think we have a lot of good clinical data. By the way, in the audience, Yoram Vardi is here. I don't know if you want to wave your hand, but he, in 2010, really initiated shockwave therapy in humans, and he gets the credit for all of this. The pilot study we did in San Diego was an open-label, single-arm study in 23 patients. We used the energy level that we talked about. We did 6 sessions and 5,000 shocks per session. So the 3 variables, number of shocks per session, how many weeks of treatment, and the energy level are described here. And we had 70% of patients with increased ability to have sexual intercourse. That brought us to the FDA, and now we're doing the pivotal trial for this particular device. This is my colleague who spent 3 years with me in the East Coast, Dimitris Hatzichristou, and he did this study, which is a fabulous study, a dose-response study. And he did once a week for 6 weeks, and then he did 2 times per week for 6 weeks. He did the traditional washout and then the follow-up. And at the end of the day, doing 2 times per week actually had better data than doing 1 time per week. The 2 times per week were red, and the 1 time per week were blue. And the mean clinically important difference in the outcome measure, the International Index of Erectile Function, was more beneficial in those patients who had 12 treatments in the 6-week time period. So in his conclusion, we have 2/3 of patients reach the mean clinically important difference using this low-intensity shockwave. 12 treatments were better than 6 treatments. Twice a week was safe and better than once a week. And the bottom line is there doesn't seem to be any negative. He did ultrasound before and after and could not see any structural changes that were negative induced by the shockwave therapy. So we are now involved in the randomized, double-blind, placebo-controlled, open-label extension of this trial. So we have a sham ultrasound or shockwave. We have 100 patients, and we will present these data to you in the future. And these will hopefully cross the finish line and get this drug approved. This is my final slide. I want to summarize. We have had penile implants in 73, 83 here at the AUA in Las Vegas. I don't know who you were there, but there was an injection at that one that really changed our field. And then in 1998, the PD-5 inhibitors became. 2010, Vardi started the shockwave. Now 7 years into this, we believe this is a revolutionary therapy that will modify, and you don't even then maybe need to get to the therapies. Or if you fail this and have to do this, maybe shockwave will get you back to first-line therapy. Or if you don't want to do third-line therapy, maybe shockwave will get you into second-line therapy. So in summary, the 51-year-old male who has moderate ED and stable relationship, maybe one day that person will be considered for safe and effective disease modification strategy through low-intensity shockwave. Thank you.
Dr. Manga, Dr. Meacham, Dr. Ramasamy. I think it's very obvious. Dr. Goldstein already said no to the answer, to the question. He is supposed to be on the pro side. So obviously I already won the debate. Do I have to continue?
Yes.
All right, continue. So I'm just going to go through the basic science part. We have been doing this for the last 6 years since Vardi told me about what he was doing clinically. So just briefly, we have done animal experiment in diabetic rats. We have done in neurovascular injury. This is the most severe kind of ED. We tie up the internal peroneal artery and the nerve. We crush the cavernous nerve. And even in those bad models, we actually saw a significant improvement of erectile function. We also look at carefully how this thing works. And finally, we conclude that this is actually a technique of in situ activation of penile progenitor cells. This is not only in the penis. Obviously, we have worked on many other organs in the body, and it's really exciting. So just as some example here, the red dot is an EDU retaining cell. I don't have time to go through the detail, but just Those are the stem cells in the penis. After shockwave, you can see so many of them actually light up red, so you know we activate the stem cells in the penis. You can look at the curve here or the number here. If you inject stem cell into the penis, within 2-3 days, they're all gone. There's nothing in the penis. They move to the lungs, the liver, the spleens. But here, when you activate the stem cell in the local natural environment, they actually stay there because that's their home. So it actually stay much longer, and you can imagine that if you do it once a week, this is going to continue. Many more cells will be there and last much longer to do the job. But in addition to the penile stem cells, look carefully. We also activate endothelial cells in the blood vessel and the Schwann cells in the nerve. So what I want to tell you is that this is a technique, and you can be proud of, that we developed in the urology laboratory. All the smart people are doing the traditional type of stem cell therapy, taking cells from embryo, from the fat, from the bone marrow. But we not so smart, but we actually developed, I call it MCAT, so everybody can remember. It's a multiple progenitor cell activation therapy, not just one cell. And they can work together. So theoretically, this is a much better, much simple and non-invasive treatment for stem cell activation. So you can see that we are doing clinical trial. People are doing clinical trial with this technique. So this is going to move much faster than the traditional stem cell therapy. Now, how does it work at the molecular level? So when you have a sound wave, acoustic wave going through a cell, basically the place that absorb the energy the most is the cell membrane, the mitochondria, and endoplasmic reticulum. Mitochondria, you actually release ATP for the cell function, and endoplasmic reticulum, you actually trigger something called ER stress, which goes through 3 different pathways. We don't have time to go through the detail, but we have worked out this for a number of years, so we know exactly how it happened. So basically, it has an effect, and they just tell you that this particular pathway seems to be the most important. So summarize, how does it work? If you give a mild or moderate stress to a cell, the cell created adaptive pathway, which includes stem cell, progenitor cell activation, angiogenesis, and neural regeneration through growth factor release, or SD1, F1. There's many things can happen. However, if you give a severe or prolonged stress, like you do the shockwave every day, you know what happened? The cells actually die. So you don't want to do it that way. And just another example to show you that we did this in cell cultures, give different energy. You can see that at a certain point, you have the best beneficial effect. However, if you go higher, gradually go higher, it's less and less, and then all the cell dies. So the energy level is very important. You have to use a very specific amount of energy. And just another example here, John Moho did some study in 2008, and with a higher energy, the animals actually become impotent, and because of fibrosis. So what's wrong with the published studies? You got so many different energies, energy devices. They use different kind of mechanism to generate the shock wave. They have focused shock wave, unfocused shock wave, linear shock wave. This is a picture from Giuliano. And so you can't really compare apple to oranges in this situation. In our lab, we actually spent a number of years working out and finally come up with this formula. So unless you know the machine, unless you know the energy level, and unless you can really calculate the biologic effect, you can't really do a comparison study. So I'd like to conclude with this article here. Dimitris was Dr. Goldstein's fellow, and he pointed out very nicely that you have all these different things, different energy level, different pulses, all this stuff. So you really, if you want to do a good study, you need to know exactly what kind of machine you are using. Otherwise, you may actually harm the patient more. And this is not going to work for people with such a bad disease that there's no stem cell left. All right, thank you very much.
Thank you, Dr. Liu and Dr. Goldstein. So in summary, shockwave therapy for erectile dysfunction. Shockwave therapy has been shown to safely increase erectile function scores, both in randomized controlled trials as well as single-arm studies. It's important to note that it is not FDA approved yet, and more studies are needed. The ideal patient for this treatment is someone with mild to moderate ED. In the grand paradigm of treatment of erectile dysfunction with PDE5 inhibitors, intracavernosal injections, and IPP, we believe as a panel that shockwave therapy is probably best used either before starting PDE5 inhibitors or after starting PDE5 inhibitors and men have failed. Thank you very much.
Thank you. Dr. Wayne Hellstrom, Professor of Urology at Tulane University, will lead the next debate.